Thank you very much for the invitation and giving me the opportunity to discuss on the optimal management of ascitis. Here are my disclosure. So you all know that ascitis is defined by the accumulation of more than 25 millimeters of fluid in the peritoneal cavity, and that it is a very classic complication of advanced cirrhosis, as 50% of patients will develop this complication within the 10 years after the diagnosis of cirrhosis. And of course, this is not only a cosmetic problem, as it is associated with a poor outcome, mortality reaching about 50% in patients within the 3 years after the first clinical decompensation. This slide reminds you, as previously stated, the prognosis value of 2 different stages of cirrhosis, the compensated cirrhosis and the decompensated cirrhosis, the latter being characterized by the presence of overt clinically decompensation, such as bleeding, ascites, or hepatic encephalopathy. And in this case, the risk of death is much higher. Very recently, 1.5 years ago, this prospective study was presented as an oral communication, including about 400 patients who were admitted with 1 decompensation of cirrhosis. And you can see here on the survival curves that in patients presenting with either ascites or bleeding and ascites, the probability of dying was much higher than in patients presenting with bleeding alone. And therefore, in the EASL recommendation, since the development of grade 2 or 3 ascites in patients with cirrhosis is associated with a reduced survival, then liver transplant has to be considered in these patients. This slide sums up the pathophysiology of ascites and the related therapeutic options that we have. Of course, liver transplant is the best therapeutic option as it definitively cures cirrhosis. As ascites is a complication of portal hypertension, of course, TIPS placement is a therapeutic option that has to be discussed in these patients. Splanchnic vasodilatation is also one major component of the pathophysiology, leading to an arterial underfilling, and therefore volume expansion with, for instance, albumin has to be considered. This arterial underfilling leads to the activation of vasoconstrictors and anti-natriuretic factors, leading to sodium and water retention, and therefore sodium restriction and diuretics have to be given to all patients. The last 2 therapeutic options are only symptomatic, that is alpha pump and paracentesis. And so first of all, I would like to discuss on the treatment on non-refractory ascites, that is recurrent or recidivant ascites. And you may all know that first, recidivant ascites was defined in the late 90s by an ascites that recurs at least on 3 occasions within a 12-month period despite adequate treatment. But more recently, the EASL stated that early recurrence ascites was defined by the recurrence of ascites within 4 weeks after initial control. Therefore, those 2 different entities are probably linked to a different prognosis. So what are the therapeutic options in non-refractory ascites? As previously stated, sodium restriction and diuretics have to be given to all patients. Paracentesis is a first-line treatment as it is very safe and very easy. And of course, the treatment of the underlying disease may improve ascites, such as alcohol abstinence or viral suppression, and they are therefore mandatory when indicated. And I will focus on new therapeutics options in non-refractory ascites, and we'll talk about repeated albumin infusion and TIPS placement in these patients. There is growing evidence that hyperalbuminemia is one part of the pathophysiology of ascites, and this study was published 2 years ago in the Lancet, comparing 2 different strategies in the treatment of non-refractory ascites. More than 400 patients were included, and one group received, plus paracentesis, the infusion of 40 grams of albumin twice a week for 2 weeks, and then 40 grams weekly. And this study was conducted in patients with non-refractory ascites, in patients with recidivant ascites treated with diuretics. And you can see on the left side of the slide that in the group who was treated with albumin, the survival was significantly higher when compared to patients who were treated with paracentesis alone. And moreover, the probability of developing further refractory ascites was significantly lower in the albumin group when compared to patients who received only paracentesis. Therefore, albumin infusion and repeated albumin infusion may be a good therapeutic option in selected patients treated with diuretics in case of non-refractory ascites. And now let's move on to the TIPS placement. You may all know this very nice RCT that has been conducted a few years ago and published in 2017, conducted in 62 patients with recurrent ascites. And this French study was conducted in France and included patients with recurrent ascites. In this study, recurrent ascites was defined by the performance of 2 large volume paracentesis with a minimum interval of 3 weeks and less than 6 paracentesis within the 3 months. Patients were randomized either to be treated with a covert TIPS of 10 millimeters or to be performed a regular large volume paracentesis. And you can see here on the survival curve that the probability of dying was much higher in the patients who were treated with paracentesis, and that the survival was, of course, significantly higher in the TIPS group. And therefore, I believe that probably TIPS placement should be considered very early in the course of ascites and probably before the further development of refractory ascites. In this study also, when we looked at the parameters associated with a better survival, the only factor who was associated with a better survival was the allocation in the TIPS group. So let's move on to the treatment of refractory ascites. Of course, liver transplant has to be discussed in these patients, as previously said. And I will talk about TIPS placement, paracentesis, and I will give you a very short discussion about the alpha pump. So what should we do in our patients with refractory ascites? Should we perform large volume paracentesis or TIPS placement? And you all know that many studies have been published in the setting, 6 RCT and 7 meta-analyses that had quite controversial results. This may be related to the fact that first, some of them included patients presenting with recurrent ascites that has a different prognosis from refractory ascites. Second, that these studies were published in the era of non-converse stents, which might have modified the prognosis of patients who received the TIPS placement. And moreover, some of these studies included patients with very severe condition with a very high level of bilirubin. But I would like to show you the results of this meta-analysis of individual data, including more than 300 patients, and that has shown that survival was significantly higher in patients treated with TIPS at 1 and 2 years, and the difference was statistically significant. Of course, there were more hepatic encephalopathy in the TIPS group, but please note that the difference was not statistically significant. So this meta-analysis clearly shows that there might be a place for TIPS placement in case of refractory ascites. And more interestingly, this slide shows you that both treatment allocation, and liver function are strongly associated with the prognosis, and that probably we have to really carefully select patients and to avoid to propose a TIPS placement in patients with liver failure and with a MEL score of more than 19. So, as TIPS is probably a very good therapeutic option, how do we have to select the patients? And to me, there are really three main issues after TIPS placement. The first one is the risk of further developing liver failure and death, and of course, it's the most important factor that has to be considered when discussing TIPS placement in a patient with refractory ascites. The second one is the risk of developing cardiac decompensation, and the third one is the risk of developing hepatic encephalopathy. And as the patient may not be a good candidate for TIPS placement, or if TIPS may not be efficient enough, or if the patient develops further complication after TIPS, then I really believe that we have to discuss TIPS placement and liver transplantation at the same time in order to anticipate any complication that may occur after TIPS placement. So, we have very simple biological data in order to distinguish patients with the best outcome after TIPS placement, and you may all know these bureau criteria that are very simple. I mean, a platelet count of more than 75 giga per liter and a bilirubin level of less than 50 micromole per liter were factors associated with a significant better survival after TIPS placement. But of course, this biological data, very simple, can help the physician in taking the decision of TIPS placement. But if the patient does not meet these criteria, there is no strict contraindication for TIPS placement. It can only help the clinician in taking the decision. Regarding the risk of hepatic encephalopathy, many studies have established that there are many risk factors of developing hepatic encephalopathy after TIPS. These are the following: a higher age of more than 65, a high MEL score, a high Child-Pugh score, the presence of minimal hepatic encephalopathy, of course a previous episode of hepatic encephalopathy, and also sarcopenia are very well described risk factors of developing hepatic encephalopathy. But these items are only risk factors, and there are no strict contraindication for TIPS placement according to the risk of further development of hepatic encephalopathy. And last year, we published a French recommendation about the management of hepatic encephalopathy in patients with cirrhosis, and we decided that patients who were good candidates regarding to the risk of further developing encephalopathy were at an age younger than 65, with a MEL score below 19, a Child-Pugh score below 13, and less than 2 previous episodes of hepatic encephalopathy. And the last issue to me is the risk of developing a cardiac decompensation. Several months ago, this very nice prospective study was published in Hepatology, and the aim was to evaluate first the probability of developing cardiac decompensation after TIPS. Second, to evaluate if this cardiac decompensation was associated with a poor prognosis. And last, to try to distinguish which patients were at risk of developing cardiac decompensation after TIPS. So all these patients were performed a careful cardiac evaluation, including biological data such as BNP and NT-proBNP, and also an echocardiography. The first result is on this slide in the flowchart, and you can see that 20% of patients developed cardiac decompensation. Second, looking at the survival curves, you can see that patients who developed a cardiac decompensation had a significantly lower survival when compared to patients who did not develop cardiac decompensation. And last, the authors provided a very simple algorithm in order to select patients according to the risk of cardiac decompensation after TIPS. You can see on the left side of the slide that in patients with normal BNP or anti-proBNP and with a simple echocardiography, excluding pulmonary arterial pressure and aortic stenosis, then the risk of developing or cardiac decompensation was null. On the contrary, when you look at the right side of the slide, you can see that in patients with an abnormal biological evaluation according to cardiac function, then we have to carefully evaluate the cardiac function with an echocardiography and also an assessment of the filling pressures. And you can see that if there is an abnormality in the assessment of the filling pressures, then the patient has to be considered at high-risk decompensation, at high risk of cardiac decompensation, and therefore probably that TIPS placement is not the best option for this kind of patients. So we have to carefully select patients according to the risk of liver failure, of hepatic encephalopathy, and cardiac decompensation, but should we also select the kind of TIPS? And several weeks ago was published this very nice retrospective study evaluating more than 100 patients who were performed TIPS either for refractory ascitis or for secondary prophylaxis of bleeding using two different kinds of stents, 8 or 10 millimeters. And you can see here the results of the Kaplan-Meier analysis comparing one-to-one proportionally matched patients with either 8 or 10 millimeter stents adjusted for age, MEL score, and bilirubin concentration, which are factors associated with the prognosis after TIPS. And you can see that obviously the survival was significantly higher in patients who received the 8 millimeters TIPS. So probably we have to select the best tip for the best stent for the best candidate. So just to sum up, probably in ascites, we have to discuss on TIPS placement very early in the course of ascites in patients with good liver function. So we have to make a careful selection, not too late, in patients with bilirubin level of below 50 micromole per liter, a platelet count of more than 75 giga per liter, with a good liver function, with no chronic hepatic encephalopathy, and at least less than 2 previous episodes of hepatic encephalopathy. Of course, we have to exclude strict contraindication to TIPS placement, such as evolutive infection of pulmonary hypertension, and we have to select patients according to the cardiac risk with normal biological data and echocardiography. So if the patient is not a good candidate for TIPS placement, then we have an alternative, and I mean an alpha pump. And you all know that alpha pump is an implantable, programmable, and rechargeable pump system that diverts ascitic fluid from the peritoneal cavity to the urinary bladder. This requires, of course, an antiviral prophylaxis. And to date, one RCT has been published comparing alpha pump and paracentesis in patients who had a contraindication of TIPS placement. And you can see on this slide that first, the proportion of patients with large volume paracentesis was significantly lower in the alpha pump group. That second, the number of paracentesis was significantly lower in the alpha pump group. And last, that the quality of life was significantly better in the alpha pump group. There was also a trend in the improvement of nutritional status, also the difference was not statistically significant. So in summary, here are my conclusions regarding the management of ascites. As ascites is associated with poor prognosis, discussion of liver transplantation has to be done. Diuretics, sodium restriction, and treatment of the underlying disease is mandatory. I think that TIPS should be discussed very early in the course of ascites, and if the patient is discussed for TIPS placement, then the liver transplant has to be discussed at the same time. And also alpha pump may be an alternative therapeutic in patients who have a contraindication for TIPS placement, but to me there are issues regarding the renal function, the management of the pump in patients with hepatic encephalopathy, and of course with the costs. And to date, alpha pump is not currently available in France. Thank you very much for your attention.